and it was like What just happened? You know what? Is Rachel Crumb here? Okay.
Yes, Rachel Crumb's here.
Okay. All right, I'm going to say the names I'm missing, so I didn't maybe miss somebody. Is Corey Goss here? Crystal? Aja? Oh, Corey, you're here now?
Yeah, I'm here.
You. Maria Barker? Alexandria? Well, we're missing a couple. I'll try to. Oh, Maria, there you are. Okay, let me get Maria. There you are. All right, so I did a PowerPoint, but not till chapter 20. So let's just review a couple of the things for the final review. So the symptoms of croup, epiglottitis, and foreign body. What are our symptoms of croup laryngeotracheal bronchitis?
Barking cough.
Barking, feel
Feel
like
like
cough.
barking cough,
Strider.
stridor, and of course, difficulty breathing. Okay, and we treat it with steroids and humidification. Epiglottitis,
Do not
That's
touch
where
their
don't look in
throat.
their throat.
Maintain airway.
yeah, they do tripod sitting, they drool, but they don't usually have a cough.
Prepare for intubation.
Expect intubation or trach, emergency trach. Okay. Okay. So let's go through Erickson's. What is the infant?
Trust versus
Stress
mistrust.
and mistrust.
A toddler?
Autonomy versus shame.
Shame,
Out. School age?
Initiative.
industry, and inferiority.
Okay. And what is preschool?
Initiative versus guilt.
Yeah.
And then the teenager?
Industry.
Industry.
Inferiority.
Very good.
Oh, I think I flipped it.
So out of the croup, laryngeotracheal bronchitis, epiglottitis, and foreign body aspiration, which one needs the an immunization to prevent?
Miss Shank, this is Tristel. I'm here.
Oh, okay, let me get you real quick while someone answers that question.
Is it croup?
It is epiglottitis. Because
Miss Shank,
epiglottitis, yes.
sorry, this is
Oh,
Alexandra. I'm here too.
Okay, gotcha.
So am I, Maria Barker.
All right. So the only one I'm missing is Najee. Nizia. I don't know how to say it. Anybody know?
Tige.
How do you say it?
Tige.
Yay, yes. Is she here?
She's getting on. Her computer's being slow.
Oh, okay. All right. She's the only one that's missing now. Everybody else is here. Okay. Remember, epiglottitis is usually caused by Haemophilus influenza, the Hib vaccine. So if you get the Hib vaccine, because I was telling you guys that with meningitis and with epiglottitis, we don't see it as often because we changed the frequency of when we give that Hib vaccine. Which ones are going to run fevers?
Epiglottitis.
And you may run it with laryngeotracheal bronchitis too, but you're not gonna with foreign body aspiration. Okay. What are the developmental tasks for toddlers? What do we need toddlers to learn?
Independent walking.
They're learning pottery,
The
their
play.
autonomy, how to dress themselves, do things for themselves. What about temper tantrums? What does your book say we're supposed to do for temper tantrums?
Ignore it.
Ignore.
and then ignore it.
Yep. Cystic fibrosis. What is the test to test for cystic fibrosis?
Sweat chloride
Sweat
test.
chloride
Red
test.
chloride. And when do we give them their pancreatic enzymes?
With
With
meals.
every
Food.
meal and snack.
Yeah.
Meal.
It's, overproduction of mucus in the lungs, the GI tract, and the pancreas. So they need what kind of diet?
High calorie.
High calorie, high protein.
High calorie, high protein. Good. And then we need a lot of breathing treatments and the chest percussion. Okay, let's talk about the pain scales. What's the visual analog scale?
Faces.
It's like a line, and then they just mark on the line from lesser to more. So what age group could do a visual analog scale?
Like 5 and up. Thought it was 8.
7.
I would say later school age, adolescent. Just like the scale of 1 to 10, later school age and adolescent. What about the face and the Oucher scale?
3-year-old.
You're going to do maybe toddler, preschool, and maybe early school age. What about the flat scale?
Infants.
Infants, newborn.
Infants or even a toddler if they can't figure out the face scale. When a child is dehydrated, what is the first treatment we try?
Oral rehydration.
Oral rehydration. Then we go to IV. If we were trying to see how dehydrated an infant is, especially a young infant, what might we do to determine how much fluid he's lost?
Weight.
Yep. Weight, because of the ounces. All right. I put this under week 4. Oh, before we start though, for your clinical eval, there is a place to put clinical evals in your bright space class. In lab, your lab evaluation with your checkoffs, that has to go under the growth and development spot.
So
Okay?
when we were in lab, because we didn't know that it had to go under there, we didn't get copies of it. They have it in the they kept them.
You didn't take a picture of it?
No,
They told us not to.
they told us not to.
Well, that's stupid.
They
If
said we don't normally upload lab evaluations, just clinical evaluations.
Well, that's not the way it is now, and you all have an effing lab right now because that's not uploaded. So, who is going to be on campus tomorrow? What group?
Group C.
All right, Group
I think
C,
C and
get
D.
yours back. Group A is done. So,
Group D tomorrow as well.
okay, so you guys can take care of that. Group A, you're all done. So I'm going to see if we can get it emailed to you so you can upload it in the lab under growth and development.
Also for Group B.
Oh,
Group
okay.
B. Yeah. We finished lab as well.
When we go for our ATI today, we could probably ask her for them and just take pictures of them.
Okay. All right. But it's because I know Missy's on vacation. So if nobody's there to find it for you, let me know. Somebody email me, and then I will try to email them all to you, Group A and B. Okay? So I can get you to pass lab.
Miss Shank,
Yes.
I'm here. TJ.
Oh, you're there. Okay. Well, we're all here. Let me just find her name on this big long sheet I have. Okay. All right.
Okay.
So pyloric stenosis, remember, was the projectile across the room.
Mhm.
They're constantly hungry. They lose weight because they don't keep anything down. They get dehydrated because they can't keep anything down. And they have that olive-shaped mass that you can sometimes feel because that pylorus area is enlarged. It's got too much muscle there. So what they have to do is cut away that muscle. Okay, but that hard muscle area is what's going to let you feel that olive-shaped mass. So the surgery, of course, is a pylomyotomy. And this usually happens around 1 month, maybe 2 months, but it's early. Okay. So a 5-week-old infant's brought to the clinic for projectile vomiting. Which of the following findings would support the diagnosis of pyloric stenosis? Pick all that apply. So what are you going to pick?
B, C,
B,
D.
B,
B.
and
What else?
B, C, D.
B, C, and D. Okay. Intussusception was when that bowel wraps up inside itself. It telescopes up into itself. It's a sudden onset of crampy abdominal pain, vomiting, current jelly stools, sausage-shaped mass in the upper mid-abdomen. So it usually happens right here where the large intestine is starting. That's where it happens. It doesn't seem to happen anywhere else. This is left over from something from in utero that will cause this. If it resolves on its own, they're going to have a normal bowel movement. All of a sudden, they'll have a normal bowel movement. Then you say, oh, it resolved on its own. If it does not resolve on its own, we do the pneumonic or air enema. Again, to know you had success, they're going to have a normal bowel movement. They aren't going to have the current jelly stool anymore. This is under week 4. Hirschsprung's was the aganglionic megacolon. So this portion of the intestine, the lower large intestine, does not have ganglionic cells. Therefore, it can expand to take the stool. So all the stool backs up here above it because it can't get through. Now, a little bit might get through on its own because it doesn't expand, which is what causes those ribbon-like stool. Okay? You're going to feel that mass because all the stool is in that one part of the intestine stretching it. Okay? If it is severe, you're going to notice it right at newborn. They're not going to have a meconium stool in that first 24 hours. Older, if it doesn't show up till they're a little older, because it depends on how narrow it is, that's when they're going to be constipated. You'll feel the stool mass, and they may have ribbon-like stools. So this is the one where they have to remove this portion, give the child a temporary colostomy, and when the child grows a little bit, they can astomose this section back to this section. We are interviewing a mother of an infant who suspects of having Hirschsprung's disease. What symptoms most likely led mom to see the doctor?
3.
Number 3.
Number
Number
3.
3, foul smelling ribbon-like stools. Who has the bloody stools?
The intercession.
Interception. The projectile
Jelly roll.
vomiting is
The
The
P one.
pyloric
pyloric
stenosis.
stenosis. So celiac disease, we actually check this as a newborn blood test. They cannot have any gluten, okay? It causes damage to the intestine if they eat any gluten, which is why we need to know right when they're newborns whether they have it. Now, this is not to say that you can't eventually develop celiac disease later in life, okay? But the symptoms is the child has steraturia, fatty, gross, smelly stools. Failure to thrive because they are not digesting any of the nutrients, poor muscle tone, abdominal distension, and anemia. The only treatment is remove gluten from the diet. No wheat, barley, rye. Now, oats is in here, but you can buy gluten-free oats. So if it's a gluten-free oat, they can have oats. But otherwise, no wheat, barley, rye, or oat. And then they do a bowel tissue biopsy to test for it, and then elevated a transglutaminase antibody blood test. Okay. All right. So this is a case study. So pay attention. 4 weeks ago, the 6-year-old presents to the outpatient pediatric office with a report of sore throat and fever 2 days. Generally flushed, head, eyes, nose, throat, inflamed tonsils with exudate tender lymph nodes. Bilateral breath sounds are clear, no murmurs in the heart, erythematous sandpaper-like rash. Today, he returns to the parents, and the parent states, I noticed last night that their face was a little puffy, and this morning it was worse. I just don't feel like eating. Physical exam, lethargy. Ear, nose, and throat are clear, no exudate, no resident redness. They have periorbital edema. Lungs are clear. They have +1 bilateral lower extremity edema. These were their vitals 4 weeks ago. This is their vitals now. So their blood pressure is elevated, temperature is normal, and they've gained 2 pounds in 4 weeks. Lab tests, clear, yellow, normal pH, protein 1 plus, specific gravity normal, negative for leukocytes, nitrates, a couple red blood cells, no ketones. 4 weeks ago, their rapid stress test was positive. Their BUN was elevated. Their creatinine is elevated. Their GRF is elevated and their cholesterol is normal. The nurse anticipates that the client experiencing which one of these three underneath that line?
Acute glomerular nephritis.
Yes, acute glomerular nephritis. The treatment will include
Loop directed.
and
Mhm. Antihypertensive.
Antihypertensive.
loop diuretic and antihypertensives. Very good. So nephrotic syndrome is the one where they're not really sure why the kid went into it, but a lot of times it follows some kind of illness. Okay. The glomerular permeability increases, resulting in protein in the blood to go out into the urine. So it's going to drop in the blood, which is hypoalbuminemia, and it's going to increase in the urine, giving you proteinuria. This causes them to have edema. Recent weight gain, periorbital edema, especially upon waking, weakness, fatigue, usually normal BP, high serum cholesterol, and triglycerides. Corticosteroids, diuretics, good nutrition, prevent infection, monitor potassium level because of the loop diuretics, prophylactic antibiotics because their immune system's going to be lower with this. They can catch infection easily, and then we're just adding to the problem. So we give antibiotics in a low dose just to try to prevent any infection when they're in this syndrome. Encourage protein-rich foods because we're losing our protein. If it's massive edema, then they are on a fluid and sodium restriction. Now, with nephrotic syndrome, remember, it can come back. Okay, it can return. Glomerular nephritis was the post-strep, usually like 2 weeks after the strep throat is gone. A lot of times it's the untreated strep, but you can still get it even if your strep was treated. The immune process from the toxins of the streptococcus damages the glomerular. So we have the fever, lethargy, headache, decreased urine output, abdominal pain, anorexia. Now, this one, the nephritis, has hypertension, more of a mild edema, still has proteinuria like the other one, but this one gives you hematuria, blood in your urine. It's a tea-colored urine. For them, you have to do the fluid and sodium restriction. You have to weigh them daily, antihypertensives, bed rest, and diuretic. I didn't put diuretic under there. Treatment includes a diuretic. And then we have to constantly monitor their urine and their blood pressure. Once there's no protein or blood in the urine, they're usually getting over it. They're also going to recheck for strep. They're going to make sure that that strep cleared up. So they're going to check to make sure they don't have strep. What, Tony?
Sorry. So I was wondering, for like many children that don't get to go to the doctor and their parents just say like strep throat clears up on its own, will they get this
Not
glomerulonephritis?
all of them. Some of their bodies won't do this. But rheumatic fever, rheumatic heart disease, and glomerular nephritis are all the problems of not treating that strep throat.
And will this happen in adults also if not treated?
Yes.
Thank you.
As a child, I had chronic strep throat, which was treated, but after I had my tonsils out, I still got scarlet fever from it.
Oh, wow. That far after.
Yeah, a year after
Wow.
I had my
Now
tonsils,
that
I still had
does
scarlet
kind of
fever.
because usually
So,
it's sooner than that. But everybody's body's different. Maybe yours just kind of went dormant or something. You
and
know,
then they diagnosed me with the
late.
rheumatic heart disease as a result of the scarlet fever.
Yeah. Huh. I never heard of it being that long of a delay. But obviously it can go that long of a delay. Usually it's within a couple months for scarlet fever and rheumatic
My
fever.
tonsils were out at 4, and I had scarlet fever at 5.
Wow. Interesting. But just because your tonsils were removed doesn't mean you can't get strep throat.
Right,
I was
but
just gonna
I
say that my
had
daughter got hers removed, and she has strep throat still quite frequently.
Yeah, it's just not as bad because the tonsils get so big with strep throat that it can close off the airway. But strep throat is just a throat infection. So you can get strep throat without tonsils.
I mean, I was young, I don't remember having strep after having my tonsils out, but I did have scarlet fever.
Yeah. Huh. So this was what we talked about with the long bones in children. Remember, they have the growth plate, okay? That has to be there here, and then there's 2 up here, so that that bone grows, okay? But if it is broken anywhere on this growth plate, it can cause damage and stunt the bone growth. Most of the time, if it's just a minimal break, it'll be okay. But if it severely breaks that growth plate, then they end up having to have their bones broke. Bone grows in, heals. A couple years later, they break it again, let it fill in and heal. So the growth plate or epiphyseal plate. Hip dysplasia, that is when they are in utero, it's an abnormal hip development. So their socket, their ball and joint socket, the ball just keeps coming out of the socket. Okay. It includes dislocation, which is totally away, subluxation, which is just partial. And then, of course, we have that dysplasia of the hip joint where it does that funny click. It is congenital. It is because of development in utero. So we have Ortolani's sign, Barlow's maneuver, and the unequal skin folds. So Barlow maneuver is when you are trying to adduct the knees, bring them together, and you hear a big clunk. Ortolani's is you push them up and then out, and you hear a click. and it dislocates. Then when you hold them up, which leg is going to have more skin folds? The affected or the unaffected?
The affected.
No, the unaffected.
Oh,
So when I stand my kid up, this leg is going to be longer because it's dislocated in the hip. So since it's stretched out and longer, I don't have any skin folds. But the normal one that is attached is going to have skin folds under their butt. The Pavlok brace is the brace that we use. Like I said, if it's not severe, we can just triple cloth diaper them. But it keeps the knees flexed and the hips in abduction. So that's why sometimes the triple diapering doesn't work, because you're not keeping the knees flexed. It must be warm all the time. You can remove it for short periods until the doctor says it can be moved for longer. Okay? So they sleep in it, they do everything in it. You do assess their skin, but as it starts to get better, the doctor may prescribe that the child can stay out of it longer. Okay? There's the Barlows, the Ortolanis, and here's the skin folds at the butt and the picture of the Pavlok brace. So it's flexing the knees and keeping the hips in abduction. Ab away, abduction. The one I forgot to talk about is this one, and there is a question on the test, so I put it in here. It is congenital. When they were in utero, their foot and their ankle got turned in like this, okay? And it stayed. It didn't develop and straighten out. It resembles a golf club. So what they do is they straighten a little, cast it. Come back in about 6 weeks, straighten it more, cast it. Comes back in about 6 to 8 weeks, straighten it more and cast it. Okay, until the foot is now in the right position. So it's a weekly, I'm sorry. Serial casting weekly until it stays in the right position. Infantile. Infantile is caused by your staph infection, Staphylococcus aureus. They are weeping lesions, honey-colored crusting lesions. It's highly contagious. They not only get oral antibiotics, but they have antibiotic creams to put on the rash. They cannot go to school as long as they have any of the drainage, okay? Because it's highly contagious. Infantile is just spread from person to person, okay? So we just have to make sure we're doing good hand washing, cleaning the crust off, and make sure they're on the antibiotic. Ringworm artinius. This is our fungal infection. Tinea pedis, foot, also known as athlete's foot. Tinea corpus is the arms and legs. See, now, I always learned that tinea corpus was arms, legs, and trunk. I never heard of tinea versicolor before. But evidently, your book breaks it down into corpus is the arms and legs, versicolor is the trunk. Oh, and I spelt capitis wrong. Tinea capitis, that Y should be a T. Cap, the head. Tinea curis is the groin. Another name is jock itch. The one thing that is weird about this is, did you know that it can be carried by pets? They can have ringworm and then give it to us. Interesting. Otherwise, you came in contact with infected items or an infected person. Okay? And then you got it. So, antifungal cream or shampoo, the shampoo is kind of like a body wash. So, of course, you're going to use the shampoo for the capitis, for the corpus, and the versicolor. Okay? You can even do a body wash, I guess, for the jock itch and the athlete's foot. But then you have to have an antifungal cream. It does not clear up with an over-the-counter fungal cream. It has to be a prescription strength. Okay? And then, yes, we can pass it to others. How do we prevent getting athlete's foot?
Keeping your feet clean and dry, wearing socks, cotton
Okay?
socks.
How many of you have kids in high school, junior high? Do they take a shower during gym?
Sometimes.
So you
Okay.
would wear like shoes, like flip flops or something in the shower
Flip
to protect.
flops, water shoes. Yup. When I go camping, I wear water shoes in the shower because you can get it from there. So, yeah.
My son played football in high school and they took showers and he got it from there.
Yeah. Yep. So make sure your kids have something like water shoes or flip flops to wear in the shower so they don't get that athlete's foot. Um, Jock itch is usually because of sweating and from, again, a shower room because, I don't know, it just spreads in the shower room. So this one is your capitis, your athlete's foot, and your versicolor, the one on the body, the trunk. Boy, he's got it all over his body. So usually we notice it right away and we treat it and it doesn't get bad like this kid. I got it from work working in PEDS and I had just a small area on my leg. That was it. I treated it right away and it didn't get anywhere like that. Okay, atopic dermatitis is your allergic dermatitis, okay? So, people who have allergies, asthma, allergic rhinitis, they are the ones that tend to also get eczema. Inflamed red skin that itches, and it goes away and it comes back. Okay. Good skin hydration is what we want. Remember, I told you to just pat them dry when you take the child out of the bath or shower and immediately put. And that name of that cream that I was trying to think of was that Aquaphor. Aquaphor and Eucerin cream are the two best. Lather your kid up with those after their bath. Don't dry them all the way off. So no hot water. Try to avoid what they're allergic to. And no products with perfumes or dyes. I can't remember if I told you about my son, but those antimicrobial soaps, he can't use those. He will break out with his eczema. Topical steroid creams are what's usually ordered if you can't get it to clear up with the other recommended products. And the biggest thing is fingernails short, because if they scratch it, they're going to get a secondary infection. Okay? So we got to keep them from scratching. And there is a picture of what atopic dermatitis looks like. Chemotherapy. Remember when they get chemotherapy, their white count is low, their red count's low, everything's low when they get chemo. So we have to do like a reverse isolation when they're in the hospital because they are prone to infection. Because of low platelets, they're prone to hemorrhaging. So, and then alopecia, nausea, vomiting, anorexia. All right, I need to use the restroom, so we're going to take a 10-minute. Are some people back?
Yes.
I'm here.
Yes.
What did I forget to put under the chemotherapy that people get with chemotherapy? Anybody remember? Say it, Tony. Don't just point.
I wasn't sure if I was right, but now I'm forgetting the word. Their mouth sores and needing to like use a
Stomatitis.
sponge.
Called
Yeah.
stomatitis. Stomatitis, mouth sores. Thank you. Iron deficiency anemia. Remember, low iron, then if we don't have enough iron, we can't produce hemoglobin. If we can't produce hemoglobin, we're not getting enough oxygen, which is going to cause us to be fatigued, pallor, all that good stuff. So it can be unresolved iron deficiency as a baby. Remember, we have mom's iron stores for like the first month or two, okay? But maybe mom was iron deficiency and we didn't get that as an infant. Then it normally drops off, our hemoglobin drops low because we lose mom's, and then it picks back up as our body starts to produce. Well, then we have problems with the toddler because they're picky eaters. You know, I think I said my son for a while there only ate hot dogs. You know, we did all kinds of different hot dogs. They are not iron rich foods. Milk has low, it doesn't have any iron, it's low in iron. So if they drink a lot of milk when they get off formula, again, it causes a problem. And then certain conditions that affect nutrient absorption, what, you know, a failure to thrive. If the child is vegan or on a vegetarian diet, they tend to have low iron. So when they have iron deficiency anemia, they have fatigue, they have cold hands and feet. Why do they have cold hands and feet?
Poor circulation.
Poor circulation, slowed growth and development, poor appetite, rapid breathing, behavioral issues, and unusual cravings, that pica we talked about. PICCA, craving non-nutritive substances. We talked about
Pica.
ice. People who chew ice, you know, crave chewing on ice is a sign of iron deficiency anemia. That's usually in the adults, but it's still a sign. So what are we going to do for iron deficiency anemia? Child comes in, he has iron deficiency anemia. What is
We
you
have
as
to
a nurse
choose it.
going to... I didn't hear you, Lee.
Give iron supplement.
Yeah.
Iron supplements, and
Choices.
then what else are we going to have the parents do?
Is that like increase the diets with
Yep. So
meat?
what foods are we going to have? What foods have a lot of iron in them?
Like
Red
meat, red meat?
Yep. Red meat, soybeans, green leafy vegetables.
Green leaves.
Lead poisoning. These are the signs of lead poisoning: headache, stomach pain, fatigue, anemia, learning problems, vomiting. So what is it going to cause if we don't catch this and their lead gets really high? Developmental delays. So it comes from paint, water from pipes, ceramics, toys that have lead paint on them. These are the blood levels. Okay. So if it's greater than 40 or less than 44 and they're symptomatic, we don't do the chelation therapy. 10 to 19, we just need to remove the lead from wherever they got it and then keep following up. 40 to 79, they're going to get a referral and they probably will start getting chelation therapy. And then if it's above AG, it is an urgent problem. Okay.
Okay, why are we not doing anything when they are less than 44, but then from 40 again, we are doing something?
Well, if they're not, unless the patient's symptomatic, we don't do it. It says that no therapy unless they're symptomatic. Because at that, if they're not symptomatic, we could probably do like we did in one and just try to remove where they're getting their lead from, and hopefully the body will take care of it. If it's that low, the body might be able to get rid of it. But when it
Okay.
gets above 40 or 44,
Okay.
then they can't. The body can't get rid of it. It's on its own. Even if we remove where they're getting the lead from, it can't. So we have to then do the chelation therapy and try to get rid of it.
Yeah, okay. I thought it should be above, if it's above 44 to 79, we should refer.
And you're
That's
probably
what
getting chelation therapy at that time also.
okay.
Anything
Thank you.
now above the 40, you should be getting the chelation therapy. And that binds with the iron so that then the body can get rid of it in excretion. Sickle cell anemia, remember it's an autosomal recessive. So if both parents are carriers and the child gets both the carrier genes, then they have the disease. African descent, the sickle-shaped red blood cells, and what happens is they go into vaso-occlusive crisis. It is multi-system. Those blood cells can clump in your veins or arteries anywhere. Okay? This is why it's such a big deal that we keep these kids from going into crisis. Every time they go into a crisis, it's an organ or tissue that is not getting blood supply. It causes ischemia to that area. It's very painful because it's not getting blood supply, and leads to multi-organ dysfunction. Treatment is morphine IV, oxygen, rest, elevate the swollen extremity, hydroxyurea medicine, and L-glutamine medicine. So to prevent this, we don't want him to get infections. We don't want him to get dehydrated, and they need to avoid extreme heat and cold. All of those things can throw them into a crisis. You can go into a crisis anyway, but if we try to keep these things, maybe they won't go into crisis as often. So these are all the complications, depending on where the blood supply is being prevented from doing. So stroke, neurocognitive deficits, a TIA, intracranial hemorrhage, cardiomegaly, so you have an enlarged heart, you can have a heart attack, retinopathy, because you're not getting blood supply to the eyes, lung disease, pulmonary hypertension, splenomegaly, enlarged spleen, priapism in males only, that is painful erection, episodes of avascular necrosis to the hips, shoulders, any of your bones, osteomyelitis, jaundice. It can affect the gallbladder, leg ulcers. I mean, renal failure. There's just, depending on the symptoms or, where the blood is clogging, causing the ischemia, all of these things can happen every time they're in a crisis. I don't know why they changed the name to this. So you will hear it either immune thrombocytopenia or you may hear it called idiopathic thrombocytopenia. Okay? Back in my day, it was always idiopathic, and then they changed it to immune. It's a response that happens after a viral infection. So the virus produces antiplatelet antibodies. Well, if we have antibodies, it kills it, right? So it's killing off your platelets. It usually does just kind of go away on its own. The body just takes care of itself. The signs are petechiae, purpura, excessive bruising, bloody nose, gum bleeding. And we usually find out that the child had a viral infection like 2 weeks ago. Observation is what we usually do. We keep track of the blood work. If the blood work starts showing a lot of damage to our platelets, we're going to get corticosteroids and IV immunoglobulin. Now, because their platelets are already low, no aspirin, no NSAIDs, and no antihistamines. Antihistamines will play a part in the platelet destruction, making the blood thinner. This is what the petechiae and purpura looks like. Hemophilia. Hemophilia, again, is a genetic disorder. It usually happens mostly in males, and they just bleed. They can bleed into their joints, causing pain and swelling. They can bleed in their lungs, causing coughing or vomiting blood in their stool or urine. Their muscles can bleed. They bruise easily. Most of the time, parents know if they're a carrier, but just in case, we should be checking it. But anyway, it is giving the clotting factor. And they usually sometimes they have a port or a PICC line, usually a port, so that sometimes the parents can give it. You can give it sub-Q or IV. And then this is what I was talking about. Remember I said there was that new gene therapy they were coming out with? It delivers a functional gene to restore production of the missing clotting factor. They are having some success with that. Okay, so let's hope that gets widespread and then we can get rid of hemophilia because we got the gene. They're also trying to do that gene therapy for sickle cell anemia. So we'll see where they get from it. ALL, acute lymphoblastic leukemia, the most common leukemia in children. ALL. So the lymphoblasts that produce the white cells are abnormal and immature. They cannot fight infection. And then as they grow abnormally, they replace the normal healthy white cells. Chemotherapy is the only thing we do for it. These kids have recurrent infections, fever, fatigue, pallor, unusual bleeding and bruising, abdominal pain, nausea, vomiting, bone pain, headache, So everything gets decreased because these abnormal or immature lymphoblasts keep the bone marrow from producing the hematocrit, the hemoglobin, the red cells, the platelets. White cells may be normal or decreased. So bone marrow aspiration and a blood smear. Those are the two things they do to see those lymphoblasts and then diagnose it. And this is just a picture again of all the symptoms that we get when we have symptoms of ALL. Hodgkin's disease, malignant B lymphocytes grow in the lymph nodes. Hodgkin's disease, the lymph nodes are more towards the surface, the ones that you can feel, okay, under your arm, in your neck, in your down here, in your. The only way that we usually diagnose it is by doing a lymph node biopsy, and that shows those Reed-Sternberg cells. Recent weight loss, fever, drenching night sweats, anorexia, malaise, and skin itching, pruritus. And of course, you're going to have swollen lymph nodes, okay? Chemotherapy and radiation. Now, radiation is if the lymph nodes are really big, they will do radiation to that area of lymph nodes that are really enlarged. Osteosarcoma is the bone, the tumor in the long bones. It's usually in children only. We have to remove the tumor and do chemotherapy. The last resort is amputation of the limb. Hopefully, we caught it early enough that we do not have to amputate their limb. They have dull bone pain, limp, and limited motion of extremity. Now, some people say that kids get growing pains, and so they might miss that it is actually an osteosarcoma. So even if your kid has growing pains, which some kids do if they have rapid growth, you should always get bone pain checked out by a doctor, okay? Just to make sure that it is just growing pain and not something else. Wilms tumor is the one in the kidney. It usually affects just children because it has to do again with in utero. Usually when Wilms tumor is found in your toddler preschool, okay? Abnormal kidney cell growth. So rapidly enlarging abdominal mass is felt, and then the parents bring them in. We do imaging, biopsy, but remember, we don't, it's Wilms tumor is encapsulated. So we really don't want to puncture that capsule. So we don't want to do a lot of palpating the abdomen because of the fact that then we can pop the capsule and spread the cancer. Usually it is removing the kidney. Sometimes they will do chemotherapy even after they remove the kidney. Okay. Sometimes they may just try to remove the Wilms tumor. Majority of the time, rather than risk it spreading and metastasize, they just remove the whole kidney. Juvenile idiopathic arthritis is the same pretty much as an adult. It is an autoimmune disease. You just now are getting it as a child. Just like adult rheumatoid arthritis, it targets the joints, causing inflammatory changes. So this is where we get the contractures, the real big swollen joints. They become red, swollen, warm to touch, stiff, especially after being inactive. So they wake up being really stiff. NSAIDs, corticosteroids, and anti-rheumatic drugs, the same drugs we give the adult, like methotrexate. The best way to keep their joints in good form so that they don't get contracted is low impact exercise. So swimming is a good one. Warm water swimming, like a pool that's warmed, is even better. Okay? But swimming is a low impact exercise. Lupus, the multi-system autoimmune disorder, inflammations of tissues and organs. They have a fever, they have that red butterfly rash, so red on their nose and then on their face. Treatment is steroids, NSAIDs, and anti-malaria medications. Again, nobody knows why some people end up with lupus. It's just an autoimmune disorder, just like arthritis. So they may have mouth, nose ulcers, the skin with the butterfly rash, endocarditis, inflammation of the sac around the heart, abdominal pain, blood, anemia, high blood pressure, muscle pain and joint pain, swollen joints, pleuritis, pneumonia, pulmonary embolism, pulmonary hemorrhage, kidneys, blood in the urine, hair loss, high fever, and abnormal headaches are all the things that we can see with someone with lupus. And lupus is just like arthritis. You can have like an attack and then you can feel fine. So it just kinds of comes and goes. It does tend to get worse as we age, just like arthritis does. So for hypothyroidism, we can have congenital or acquired. Okay. Congenital, they're born that way. The thyroid gland did not develop. So it therefore does not secrete T3 and T4, leading to developmental delays and all kinds of other problems. If it's acquired, it could be damage to the thyroid glands, an autoimmune disease that affected the thyroid gland. And this affects your metabolic process. So congenital is present at birth with developmental impact, while acquired after birth is an autoimmune condition or an iodine deficiency. So when it is acquired, it's later and they don't have so much of the developmental delay problem. I know this didn't come out good, but children with hypothyroidism are shorter than other children, low energy levels, gain weight, delayed puberty or irregular menstrual cycles, frequent constipation, muscle cramps, slow reaction time, dry skin, and They're cold. I don't know what that says. They're cold. So when they have either type of hyperthyroidism, we need to monitor their growth, and they are on levothyroxine, like levothyroxine, Synthroid, for the rest of their lives. There's nothing else they can do. We have to replace that hormone. And then we have to periodically monitor their T3, T4 to see if we need to increase the dose as they get older. Hashimoto's disease is also hypothyroidism, but it is a sudden onset. Okay? It's enlarged, inflamed, underactive thyroid. You get a goiter. It's also an autoimmune disease, but it destroys the thyroid gland. So the symptoms are usually the same as all the other ones, but this one is usually during most of the time it's like teenagers in your 20s. Okay? It's just a sudden onset of your hypothyroidism. And it's just not slow and gradual, just bam.
There is one that we have. Is that
Juvenile diabetes, frequent urination, extreme thirst, fatigue. Management, of course, is insulin, blood sugar monitoring, lifestyle adjustments. Juvenile diabetes, we don't usually call it that anymore. We call it type 1 and type 2. Because kids now are getting type 2, the insulin resistant. If they are type 1, though, they have to have insulin. Their pancreas is not secreting any insulin at all. So what I did here was I took this out of your book that I told you guys to memorize, and I put it in the PowerPoint. For of course, if it's an infant, I've never had an infant. Okay, I'll tell you that right now. They're usually around 3 or 4 when they're diagnosed with juvenile. But if it is an infant, they can't communicate their signs and symptoms. They can't check their blood sugar. But if they do have episodes of hyperglycemia, it can affect the developing brain. So if it is an infant, parents have to be very, very on it. Take care of the child. The toddler is at increased risk for hypoglycemia because they're picky eaters. Okay. Again, their brain is developing, so we don't want them to go too high or too low. Discipline and temper tantrums make this hard. Is that normal behavior, or are they having hypoglycemic symptoms? Parents may be overcautious and hinder their child's ability to explore and develop. We still have to let them be a normal toddler. We just have to check their blood sugar and monitor their eating. Preschoolers, their motor ability is getting a little better. They're widening their social circle, and now they see that they might be different than other kids. Not all the other kids are having to poke their finger and get a shot. Not all the other kids have to watch what they eat. Remember, magical thinking is during this age. What did I do that I have this? I was bad. I did this, and this is what caused it. They also want to be active participants in their care. So we need to start letting them do some things. Can they put the stick in the glucometer? Can they push the button? Those are kinds of things to get them being interested in their care, so that by the time we get to school age, they can start doing some of their own care. The school ager, now we're trying to get them to monitor their own glucose, choose their injection sites, learn them how to give their injections, maybe check their urine for ketones, know what they can and can't eat by looking at the carbs, know the symptoms for hypoglycemic, and they start relying on others than just their parents, the school nurse, their teacher. Again, they might struggle because they're different from their peers and they might have social problems. They need to learn how to incorporate their care into their school day. The adolescent is undergoing, all their hormones are going crazy. They're growing fast, cognitively, physically. And they're doing that identity versus role confusion. So this also struggle with independence. They might not adhere to their regime. They have that body image. They like junk food. They don't want to be different from their peers. So they don't always follow it. We need to make sure they follow their plan of care so they don't have long-term consequences. A nurse is teaching a school-age child who has type 1 diabetes, mellitus, and his parents about illness management. Which of the following instructions should the nurse include? Anybody?
Letter
Two,
B,
Which one?
two.
not,
No.
I
It's,
think it's 3.
yep, we're going to start teaching them to check the urine. When do you need to notify that your blood sugar, especially in a child? When it's over
I thought,
250.
oh, 250, okay.
Yeah, 350 is extremely high. They should have
High,
called the
okay.
doctor when that child's got to be 250 or higher. So it's testing the urine for ketones. Now, we don't
Okay,
check for ketones in adults like we used to, but periodically we still do it for the child, okay? Because they'll spill ketones in their urine. The nurse is performing an assessment of a school-age child and noticed the client is requesting to use the bathroom often, has asked for water multiple times in the last couple of hours, and is requesting extra snacks following breakfast. The child's weight is trending down over the last few days. What do you think this child has?
Is that 3?
no,
No, it's type 1.
no, it's type 1. Yeah.
Yep. Polyuria, polydipsia, polyphagia.
Only-
Down syndrome, it is a chromosome where there's an extra chromosome and chromosome 21. It affects physical, it's called trisomy, um, physical and cognitive development. They have different facial features. They have a flat, broad nose. Their eyes sometimes slant. Their ears are low set and their face is kind of round. Developmental delays and varying degrees of intellectual disability. That you can have someone on the low end of the continuum up to high functioning, okay? And anywhere in between. Early intervention and support is very important for kids with Down syndrome to live a healthy, fulfilling life and participate in society. A lot of them have hearing problems and eustachian tube problems. Some of them are born with the ventral septal defect. But They have low set, small folded ears, short neck. See the slanted eyes, and then the broad, flat nasal bridge. Okay, let's see. Let's talk about the heart defects. Which one causes increased pulmonary blood flow? Causes the blood to go back to the lungs to pick up oxygen when it's already deoxygenated. There are 3 of them.
PVD. Is it?
Patent ductus arteriosus, yep.
VSD,
VSD
PVT.
and ASD.
yeah.
Yep, the one between the 2 atrium, 2 ventricles, and the patent ductus arteriosus. Which one causes decreased blood flow?
The theta, the T1s.
Very good.
Petrology.
Pathology of flawed and the one where you have the stenosis.
Stenosis, yeah.
Okay. I knew what you meant. All right. Anything I can cover. Anything you need to have clarification on.
I'm gonna say.
You know, I do have a question about vitals. When you say vital signs in a test, are we just talking about like the 5 standard vitals, like the heart rate,
You
blood
know
pressure?
what? We're pretty much talking about just the infant. Where do you take the infant and toddler's pulse?
Apical.
Apical and for a whole minute. When we're taking vitals, what one do we do very last on the infant and toddler? The blood pressure is always last. No. And I don't always like the temperature either. It's easier to get the pulse and respiration first, then the temp, and save that blood pressure for last.
Stella, I think you're unmuted.
Yeah, somebody needs to mute. At what age do we start doing regular blood pressures?
Was it 2 or 3?
3.
3.
Otherwise, we only do it if we suspect like a heart problem, respiratory problem, kidney problem. Anything else? I know you're like so overwhelmed. But that review is up, okay, under week 4. That PowerPoint I just went through. And if you use the study guide I made with the other stuff that's not on the PowerPoint, because that took me all weekend to make, you guys. I hope you appreciate it.
Thank you very
It is
much.
very appreciated.
I do.
So I think you guys will do just okay, or just fine and all pass, okay? All
Thank
right.
you.
I'll let
Do you know how many questions we're expecting?
What?
How many questions are we expecting on the finals?
Hold on. It's worth 100 points. And there are, pull this up. 62.
62, okay.
So some of them are worth more than 1 point. We have some all that applies, some drop down things. Oh, Pam Biles said she fixed it. So there is a spot now in your lab to upload your lab evaluations. So anybody who does not get their lab evaluation, please email me. so that I can send you a copy. Okay? You don't get, it stays an F until that's uploaded. It's just the way they made it. So please email me if you don't get it today when you go on campus. Okay?
Thank you.
Anything else? All right. Eat a lunch before you go for your ATI, but don't overeat that it makes you sleepy. Okay? All right. See you guys later. Bye.
Thank you.
Thank you.
Thank you.